Okay, good afternoon, everyone, and welcome to another edition of Friends Talking. This is our first meeting for the year 2025, and I'm so delighted and happy to see everyone. I hope you all had a wonderful Christmas and a wonderful New Year, and we are ready to have some interesting conversations for this year. We're kicking off this year's presentations with Dr. Wilmore Webley, and he will be sharing with us this afternoon on the current outbreak of flu. It's a flu season, and almost everyone around us are getting ill. Every sneeze, you have to be watching, hey, what's going on here? So this afternoon, Dr. Webley will be taking us through what is going on and give us some insights as to how to prepare for it and how to deal with the this flu outbreak. For those of you who are new to our forum, we have this chat. The chat is here. You can put your questions in the chat. I will acknowledge. There's also an icon that you can raise your hand, and I will acknowledge you in the order in which the hands appear. And if you have questions and don't want to forget them during the presentations, you can put them in the chat. Sebastian, I'm going to ask you to pray for us to begin, please.
Let us pray. Father and our gracious God, we are so thankful to you for this wonderful, blessed Sabbath day. Thank you for this gathering. Thank you for each man represented here. I pray, O God, that you will bless us as we receive from Dr. Wilmore as he presents on this most important topic. I pray, O God, that we will receive key instructions to keep ourselves and families healthy. Bless us now as we enter into these proceedings. In Jesus' precious name I pray. Amen.
Amen. Dr. Wilmore, over to you, sir. Doc, you are muted if you're talking.
It's good to see everyone. Hopefully you and your families are doing well. I'm about to go on this presentation here just to give you a little bit of insights into what we've been seeing in terms of influenza and influenza-like illnesses. Selwyn, can you tell me if I'm in presentation mode there? Are you able to?
We can see your screen. Hmm?
Okay, good. So I'm showing this slide because yesterday I taught my first class for the semester in my infectious disease outbreaks class, and I asked the students this question: what is the most important or significant infectious disease issue on your mind this week? And you can see in the word cloud there, the bigger the word, the more people who said that was a concern, and bird flu was right in the middle there. You can see that there's also influenza and stuff about raw milk and stuff about anti-vaccine sentiments and policies, and of course RFK Jr. And duck and flu. And so you can see that, you know, the students have their fingers on the pulse of what is happening across the country and to a great extent across the world as we went into it. So, you know, I'll just dive right in. We're in what we call influenza-like illness season. And this doesn't just include influenza, it includes the common cold, it includes RSV, it includes a whole host of other things. And as you can see there, for the US, we're seeing COVID numbers are high, flu numbers are very high, RSV numbers, this respiratory syncytial virus, numbers are moderate. And why do I put all of these together? Because you wouldn't be able to tell right off the bat which one you have. They're all respiratory infections with very similar initial symptoms. Of course, if you're losing your sense of smell and taste, then you know you have COVID. If you're having, you know, severe joint pains and stuff like that, you probably have flu. but it could be very hard to tell unless you actually get a test to look at this. And then we look at emergency department visits, and you can see that for COVID, people are not going to the doctor a lot for COVID. And the reason for that is because so many people have either been vaccinated or have had COVID in the past, so they have some level of protection. But flu is high, very high, and increasing, the number of hospital emergency room visits, and RSV numbers are moderate. So around this time, it wouldn't be surprising if you came down with something. And so when you look at here again, you can see the numbers of people. These are direct numbers of people by percentage now. You can see that emergency room visits for influenza are way above the other two. What I want you to notice on this last graph, though, is what we've been seeing this season, that the vast majority of people who are ending up in the emergency room are 0 to 4 and 5 to 17-year-olds, where these respiratory illnesses are concerned. And this doesn't reflect the mortality rate, because of course the mortality rate is higher for those 65 plus. But the people who seem to be most impacted are those who are found in congregate areas, mainly school, for school-age children and daycare and stuff like that. So you should look out for that. So the level of activity across the United States is pretty high right now. These are acute respiratory illnesses, and all of the U.S. territory. You can see that if we look at areas like Texas, Florida, South Carolina, New Jersey, New Hampshire, Wisconsin, Oklahoma, these are areas that are very, very high levels of respiratory illnesses, more moderate levels across most of the West, California, and other areas, and then, high levels coming into Midwest and Northeast. So again, we're really in the peak of flu season. Flu is interesting for many, many reasons. And I always tell my infectious disease students that we talk a lot about a lot of different respiratory illnesses, but influenza gives me a lot of concern. And this is one of the reasons. When you look at the most recent history of influenza, you can see that, there was a Russian influenza outbreak in 1889 to 1890, accounting for the deaths of about 3.7 to 5.1 million people. And these ranges are wide many times because, you're looking at what the excess death says and then what the direct diagnoses say. Lots of people would die from this, therefore, and they're not diagnosed as such. But by far the one that we remember is the 1918-1920 flu pandemic that came right around the time of World War I and killed anywhere between 50 to 100 million people. And it's called the Spanish flu, not because it started in Spain, but because Spain was a neutral country at the time and was the only one willing to report the total number of deaths that they were having. The other countries, including the United States and most of Europe, just wouldn't report that because they didn't want to demoralize the fighting troops more than they were already demoralized. But many of these troops went into battle and died from influenza. This was an H1N1 influenza. And then, of course, the Asian flu, 1955 to 57, the Hong Kong flu, the swine flu of 2009 is our most recent one. But in any typical flu season, you could have anywhere from a 250,000 to 500,000 people dying worldwide in a flu season. So in other words, the flu is not something to fool around with. So you heard me say H1N1, and you might hear about this H5N1 bird flu that we're talking about. And so I'm going to share a little bit of biology with you. I'm running a risk doing that. I don't want you to tune out, but this H and N come from somewhere. So this cartoon, a highly stylized cartoon, shows you the surface of a typical influenza virus. And whether it's a bird flu or some other type of flu, all your influenza viruses look similar in this regard. And they have on the surface two important proteins: the hemagglutinin protein that we call HA, and the neuraminidase protein that we call NA. The HA protein is important to the virus and important to us because that's how the virus gets in. It binds to a receptor in our upper respiratory tract called sialic acid. Now, it turns out that sialic acid in different animals have little variations in terms of the way the amino acids look. And so the viruses that bind to human HA won't necessarily bind to a bird HA or to an HA that you find in some other animal. And we'll get back to that a little bit. And so this is important for binding. This is the glue, essentially, that the virus uses to attach. It needs the NA because once it's attached and replicated, it needs the NA, like a scissors, to clip it from the cell so that it can be active and go out and lead to a productive infection. So this is the membrane of the cell that you're seeing here. Here are the sialic acid residues, and these are the receptors that it binds to. So keep that in mind. So, you know, the influenza, therefore, is this virus that has different family members. The ones that we talk about the most are your influenza A viruses. The B viruses also infect humans. C virus is called myeloepidemic, and there's also a D virus that we won't get into. So pretty much all of the pandemics that we've had have been influenza A viruses. So these are the ones that we're actually talking about now. H5N1 is an influenza A family of viruses. So these are just family of viruses. And the H1N1 or H2N1 or the other combinations has to do with the variation or variability in the hemagglutinin and the neuraminidase protein. In other words, as these proteins mutate, either through what we call antigenic drift that I'll talk about or a dramatic shift, the virus is able to evade the immune response because the antibodies that were made against an H1 virus doesn't recognize an H2 virus. And as a result of that, the virus is able to evade. And those that bind to an H3 virus doesn't recognize an H5 virus, and so on and so forth. And so these variations are important to the virus in order to get it to evade. You could have new viruses created because of this mixing as well, as they transit through different hosts, like what you're seeing here, through a mixing of the genes. So each one of these influenza virus particles has 8 different RNA molecules or RNA strands in it. And each one of those RNA strands code for a separate protein. One of those proteins is your hemagglutinin. Another one is your neuraminidase protein. But it has other proteins that it has in its system that it is necessary as structural proteins and for other purposes. And so the viruses are named based on, number one, the strain. I told you about the A, B, C, and the D viruses. So here is the nomenclature here, where this is an A virus. The Fujian is the geographic region that it was found in. The strain number, as they find different ones throughout the year, they number them sequentially. And then this is the year in which it was found. And the H3N2 is the variation in the hemagglutinin and the neuraminidase protein. And this is how virus strains are tracked. This, of course, you have to get through genetic sequencing of these viruses. And over here, as you can see, you have quite a variety of H and N subtypes from the virus. As I said, your influenza A virus infects a wide range of animals, including birds, but infect humans. Your influenza B mainly infect humans. The C can infect humans and pigs. And of course, D can infect cattle. It doesn't mean that this is where they're found exclusively. This is just where we typically see them. Now, I talked a little bit about the differences in their ability to infect different hosts. And again, here's the HA protein, here's the NA protein. This is just a depiction of it. And where you have the major variations is in these 2 proteins. So as they change, the immune system doesn't recognize them, and you have to start from scratch again to get back at them. And in this publication in Nature journal, they're showing you here that different animals, they see these alpha 2, 3, alpha 2, 6, these are the different sialic acid. These are the proteins in the airway that they bind to. And you can see that for humans and pigs, they have an interesting setup where both humans and pigs have this receptor in the upper airway and then have a separate kind of receptor in their lower airway, which means that both humans and pigs can easily get infected with influenza viruses that typically infect birds that have the alpha 2. The interesting thing, therefore, is that in pigs, you could have a really quick mixing of two different types of viruses, creating a new virus that now could lead to widespread outbreaks. And so, as I said, these different types are important because of immune evasion. So, that's what the important thing. Those little Y-shaped proteins here are antibodies. They bind to specific proteins and protein sequences on the virus, and that now stops the virus. However, if you have a variation like this new one, then these small changes cause the virus to evade our response. We call these antigenic drifts, that over time you have these accumulating mutations. However, if you have two viruses entering into one cell, they can create a new viral particle. And that now is a major shift in the way the virus looks. In other words, it's like it walks into a store in a certain type of shirt and comes out in a completely different shirt. The immune system doesn't know that is it, because it comes out in a shirt and a different type of hat. And all of a sudden you have a new virus strain on your hands. And so over time, what we've seen an adaptation of these viral strains to different animals. And over time, these minor changes that accumulate can lead to viral replication. And you can see here these changes in the receptor specificity and how the immune system actually sees the viruses over time, as you have these different changes that you're seeing here that's being depicted between a virus that was originally an avian virus or a bird virus, and then one that is a human or mammalian virus strain. I'll skip this for now, but here's the history of some of what I showed you. The 1918 flu pandemic was caused by an H1N1 virus, where mostly young people died from this virus because the older people had probably seen similar types of H or N, and that helped to protect them because they had memory of this. In the 1957 outbreak, you had an H2N2, a mutation that led to this new virus. And then you had an H3N2 for the 1968 outbreak. And then the 2009 outbreak was an H1N1, but it's different from this original H1N1, have several sequences in there. These are the RNA that you have in there that gave it a variation that, while it was very much similar to this, had significant differences. And so this is an image from the 1918 pandemic, where you have this temporary hospital set up in Kansas, where, they had to make these makeshift hospitals to accommodate the number of people who were sick. At that time, unfortunately, they didn't realize that the virus was being transmitted through their nostrils, so they actually had masks. They covered their mouths, but they didn't cover their nostrils most of the time, and so they continued to get infected. So I pulled this from the World Health Organization website, showing you the current trends and giving you a historical perspective on the number of specimens being tested and the percent positivity of influenza samples that they're getting. And so you can compare the 2020 numbers, heights, these are the peaks. And then, of course, in 2021, because of COVID and people were in, we had pretty much no flu outbreak. 2022, it came back. 2023, you can see it's high. 2024 went up, and 2025, the 24-25 peak is almost at the level that we're seeing for the last year. And it's not clear if it's already plateaued. We're waiting for numbers over the next couple of weeks to see that. The CDC wasn't able to put out numbers, but you can see that the vast majority of that is your H1N1 virus strain. That's the blue there. There are some B lineages, maybe the Victoria strain, which is actually in the vaccine, but this is the level that we're seeing here. So currently, This is the influenza map for ending in the last week over the season of the US, and you can see that influenza like activity, as I said, is just very high, pretty much in most areas. And this again is pneumonia and influenza mortality. These are the percent of deaths that we're seeing, and you can see that this year's death is actually pretty similar to what we're seeing from the past years. So while it feels really bad, this year is not yet surpassed what we typically see. But as I said, you know, quite a number of people die worldwide from influenza each year. In the United States, flu deaths are estimated to be between 11,000 and 53,000 deaths this year. Lots of hospitalizations, lots of flu-like illnesses being seen right now through flu. So a vaccine is out there. It's a trivalent vaccine this year, meaning that it has 3 different types of viruses in there. Because remember that flu vaccines are actually made almost a year in advance. You have to predict what you're going to have because it takes time to ramp up production. And between the CDC and the WHO, they look and see what is going on in Asia, in Australia, and other areas, and they make a flu vaccine looking at those trends. And in order to overcome, they actually have 3 different viruses in the flu vaccine. And that's whether it's this egg-based vaccine, in other words, they inject fertilized eggs with the virus and it replicates, and then they are able to inactivate it, and that's what the vaccine is made of. There are people who are allergic to eggs, even though the new data shows that if you're allergic to eggs, there's such little egg protein in the vaccine that it shouldn't be a problem. But to satisfy other people, they actually have cell-based vaccines, and they have the similar types of strains in there. That's making up the overall trivalent vaccine that we have this year. So in addition to vaccines, Tamiflu works really well. So does Valenza, Rapivad, and Zofluza. All of these are pretty much good treatments for the flu. Tamiflu is probably the first line of treatment, especially if you didn't get vaccinated, so that people can have it. So that's your regular flu season for you. But what is this thing with the bird flu? So as I said, bird flu is really avian influenza. It's a strain of influenza that is typically seen affecting birds. And birds are typically susceptible to it. Waterfowls can get infected with it and show very little symptoms, or they can die. And many times you see that overall. The problem is that sometimes these bird flu viruses can be transmitted to humans, can be transmitted to not just domestic poultry, but commercial poultry, poultry that is used for egg production. And that now leads to a lot of cases of infection and death, and most likely affect your bottom line in terms of how much you're paying for eggs and sometimes chicken in the supermarket. But overall, the symptoms of bird flu are similar to the regular flu: high fever, having chills, cough, sometimes sore throat. We know it can lead to conjunctivitis, difficulty breathing. You don't want to wait until that is happening. You certainly want to get to the hospital if you're having these types of treatments. But let me just backtrack a little bit and tell you a little bit about the history of the current H5N1 or bird flu or highly pathogenic avian influenza HPI that we're actually experiencing now. In 1996, in China, Guangdong province, a goose was found with this H5N1 virus in it. It was associated in 1997 with large poultry outbreaks in China, in Hong Kong specifically. 18 cases of human infections were seen. 6 people died from this virus at that time. It went on to cause about 860 human infections, and about 50% of them actually died from this virus. it kind of waxed and waned and was kind of out of sight a little bit, but continued to mutate. That's why these little arrows here, this is a genetic tree showing you mutations, and popped up again in 2003, where it emerged in China again, was spread now to other countries, and had several outbreaks in poultry farms across Asia. In 2005, wild birds actually spread it to Africa and Middle Eastern Europe, in Middle East and Europe. And they saw a diversification or a change, some significant changes in the genotypes of the original H5N1. Fast forward to 2014, there was the emergence of another type of H5, the H5N6, H5N8, and these had overlapping H5 mutations in there that showed that it had the similar lineage overall, but it was changing. And out of those changes came an interesting clade, this 2.3.4.4 clade, which has led now to this 2.3.4.4b virus strain that we have circulating currently. And that one actually started to stabilize in 2018, 2020. And so we saw that now enter Canada and the US in 2021. And since then has been spreading in an unusual way. So this is this new variant of this original H5N1 that popped up in China in 1996. And this is very typical of influenza. It will continue to mutate and change and change and change. And so what we have now is this H5N1 circulating along with regular flu. So these are the numbers of regular flu plus your H5 plus other flu strains in the United States. And you're seeing that, you know, the most recent numbers that I got from the CDC, they didn't get any samples in the last week, but there's 62 sites across the United States where they're having detection of this. And essentially what is happening, you can see it in the different states. We saw the states where you have all the regular influenza. This one now that we're seeing is where you're having higher numbers of H5. This is bird flu. And we're seeing wild birds infecting cattle, cattle infecting other cattle. We're seeing cattle infecting poultry that are on the cattle farms. We're seeing a cow to cat infection and possibly a cat back to cow infection. And we've seen cow to human infections. What we haven't seen, thank goodness, is a human to human infection of this bird flu. And that's what everybody's watching for. When that starts happening, then we have a pandemic on our hands. But essentially, the reason why there's no human to human transmission is because this virus has been adapted to bind to a sialic acid, that's your alpha-2,3, in the upper respiratory tract of the animals and the birds that it's infecting, but not in humans. The humans have an alpha-2,6 variant of the receptor in their upper airway. I hope you're following that. It's a little bit heavy on biology, but that's essentially what is happening here. And we're hoping that we don't see any mutation, any change in it that leads to a human-to-human transmission, because then we'll be talking about a completely different set of circumstances. Now, what we've seen is that we've seen about 67 total human infections in the United States. One of those, a 67-year-old man in Louisiana who had underlying conditions. They haven't said what those underlying conditions were, but it could be diabetes, it could be something else. But this person got infected with bird flu, apparently got it from their backyard where they had some domestic birds, and wild birds came to eat, which typically happens as they're migrating. They come in, they find other birds outside, they land with them, and they eat, and they transmit it in that way. And he apparently got it in through that mode. And so what we've been seeing in the U.S. has been interesting. You've been seeing these dairy cattle and wild birds, poultry flocks and mammals getting infected. You can see the numbers there, and you can get the full numbers on the CDC. The Pan American Health Organization, or PAHO, also has some of these numbers, similar to the US numbers. Of course, you're seeing the number of million outbreaks, 991. You're seeing 567 different types, different sites for flu outbreaks. But I want you to see that everywhere from Argentina to Brazil to Colombia and Ecuador and Mexico and Peru, Puerto Rico, they've all had cases of bird flu. And what you're seeing here, you're seeing the different trends of it, the number of cases popping up across the US since the early stage. And what we've seen in this current outbreak, in 2022-23 until now, not only have we seen it in these backyard chickens, but we've seen the migratory birds, waterfowls be infected. We've seen seals. We've seen cats that eat infected birds get infected. Of course, we've seen that these wild birds actually are able to infect cattle. And this is the new map of what we're seeing with this H5N1 that makes it very different from any other H5N1 that we've ever seen infecting mammals and other animals across the United States or anywhere else. And I want you to see that not only is it infecting wild cats, but domestic cats, it's infecting bears, it's infecting basically almost every canine out there, from dogs to foxes. It's affecting marine mammals. Lots of seals and dolphins are getting infected up and down the coast. We're seeing raccoons, lots of raccoons, skunks, possums. This thing is infecting just about everything. And what that means is that as we continue to interact with them, we actually are in danger of getting infected. So on my campus at the University of Massachusetts, or UMass, a couple weeks ago, we found out that the Canadian geese that typically sits around our campus pond for a long time, because they get food from the ducks that we feed there, so they tend to sit there a lot. We're noticing that a number of them were dying at the edge of the pond, and when they were captured and samples sent for testing, turns out that they're H5N1 positive. And the state of Massachusetts as a whole just reported that bird flu is widespread in the state. In many ponds and rivers and areas, they're finding wild birds and domestic birds positive for this thing. So this is now right at my doorstep, where I go to work every day, just across from where my office is, down at the pond. You have these Canadian geese that are positive, and possibly some of our ducks that are residents there. So again, this is a widespread infection for livestock. 951 confirmed cases as of January 29th in 17 different states. Here are the different states. California has really been hit hard. Colorado, the numbers are going up. And Michigan, that I'd seen a spike last year and was going down, its numbers are going up again recently. We're seeing flocks, bird flocks, commercial flocks, backyard flocks, totaling about 17.8 million birds have been affected. And essentially what happens is that when your flock get infected, in order for you not to spread it to other adjoining ones, you have to cull the entire flock. But between February 8, 2022, which is where I ran these numbers from, and now we've had about 147.25 million birds that have been recorded to be affected by this current bird flu outbreak. What that means, therefore, is that a lot of our commercial flocks have been affected, and that has caused egg shortages and egg prices to go up. I mean, for the first time, I go to the supermarket, egg prices are somewhere between $6 to $9 per carton, and we see signs like those. That there's egg shortage, and some of the shelves, specific brands are affected based on where their base is, and you just can't get eggs. For the farm workers, this was a major concern last year, as farm workers were getting infected, and it mostly presented as conjunctivitis. Turns out that it was the milk splashing in their eyes. Turns out that this virus, this H5N1, is able to infect the udder of these animals. And as they're being milked, and that milk splashes, it has a lot of viruses in there, and that's how they were being infected overall. And so it turns out that if you actually give really good protection to the farmers, having good personal protective equipment or PPE, including masks and eyewear, and ensuring that you're not having people coming on these farms from outside, and basically having good levels of protection, you can actually mitigate this. We saw a different variant of this virus, an H5N2 this time in Mexico, lead to the death of a 59-year-old man last year. And so again, we're seeing some interesting variations in this. And the outgoing, most recent CDC director, Dr. Mandy Coyne, actually gave some explanation here for this current outbreak.
So with regards to avian flu or bird flu, we are definitely taking this seriously. This is the first time we are seeing avian flu in cattle, in cows. We haven't seen that previously. Obviously, it had been in chicken, poultry before, and that is where our heavy efforts have been in terms of monitoring. So the fact that it is in cattle now is definitely raises our concern level, and we have some work to do to better understand that. The virus is the same strain of the virus that we have seen in chickens in the past. So it's not a new strain of the virus. So this is known to us, and we've been studying it. And frankly, we've been preparing for avian flu for 20 years. Unlike COVID, which is a completely novel or new virus, avian flu is known to us. And we've been thinking about vaccines and treatment and tests for quite a number of years. But this is a new development. Cows, mammals, being a reservoir gives this virus new opportunity to change. And that's what we're watching for really closely. Has this virus changed, or is it changing that would make it more likely to spread from human to human? The good news is, right now in the United States, we've never had a documented case of human to human spread of avian flu. But that's what we're watching for to understand how this virus is changing. Today, it's the same version of the virus. But as we've all learned through COVID, these viruses change very quickly. So we are needing to watch it closely. We have to sequence these. We have to stay ahead of it.
So that's where we're at. So here is my biggest concern. My concern is not necessarily the antigenic drift, the regular mutations that the virus picks up, this one change in an amino acid here or there. My concern is a reassortment. And by that, we mean if you have the current seasonal flu, which is an H1N1, infecting the same person who has the bird flu, you could actually have a reassortment where you have the same virus that's infecting coming out, but you could have a new virus being created with a mix of the two viruses that came in. Essentially, think about going into a swimming pool. You take off your clothes, 2 or 3 people go in this case it would be 2 people. And when person A comes out, they pick up person's B pants and put them on, and put on person B's hat and come out. And somebody now seeing that think it's a different person. And that now is what the immune system will see. The immune system will be naive to these viruses. It wouldn't have been prepared fully to protect us from that. And that could actually now give a new virus some capabilities they didn't have before. So let's say it picked up the gene, that the bird flu virus picked up the gene that codes for the HA for the human seasonal flu. So now it with the bird flu, but now it's a part of its HA would be able to bind effectively to the upper respiratory tract epithelial receptor for human, and that now could be problematic. So that is my, and I'm simplifying it because it would probably take additional mutations for it to efficiently be transmitted from human to human. But that really is my concern right now, that we're in the middle of flu season, and this could be a problem. So I will end there by showing you um, uh, essentially what we see as issues that could come up, and how you can protect yourself. Essentially, avoid touching dead birds. If you have cats inside, don't let them go out where they could potentially eat those birds, and that could lead to problems. Wash your hands, avoid contact with anything that's sick or dead or dying. Cook your food properly, especially your eggs, and that might give you some level of protection. So the main takeaway here is essentially that there's no evidence of human-to-human transmission at this stage in the U.S. or anywhere else that we've seen, and that is the best news. The greatest concern is for me is mutation plus reassortment. Cattle movement is certainly a problem. I think they're just getting their hands around that now. But again, with the circulating H1N1 mixing with regular, with the H5N1, that would be a significant concern for me. And I'll stop there.
Okay.
And we can start having a conversation.
Okay, doctor, thank you very much for that insightful and thought-provoking information on what is currently happening in our environment. Just a couple of observations, and then I'll open. I have a friend who just this week came down with the influenza, and apparently it affected the person so badly that apparently they went to the restroom during the course of the night and literally passed out. I'm wondering, and they were telling us that it's the influenza A. And I just wanted to find out, is it that dangerous that it can cause someone to block out because of the nature of what is going on in the body? What are your thoughts potentially on that?
Yeah, this is not atypical for your regular seasonal flu. That it can lead to all of those symptoms that I just showed you. And if you're having diarrhea, and you're having other symptoms and you're not hydrating, then that absolutely can lead you to have issues and pass out for sure. As you cough and have respiratory distress, that can lead to hypoxia, and in a very short time, you could be in trouble. And that's why if you're having those acute symptoms, you certainly want to go see a doctor. Having high fever, having chills, those could be very much signs of having influenza.
Okay, and then I'll ask one more question and then open it up. What are the distinguishing features of bird flu versus COVID?
Very hard to tell, especially initially. As I said at the top, both of them are going to cause you to have fever. Both of them can cause you to have some level of chill. The difference would be if you start having things like you're having loss of taste and smell, then that will be COVID. COVID typically doesn't cause as much joint pains as the flu will. Kind of that joint pain disorientation that the flu causes, but those are not consistent symptoms. You really need to do a test. And so, you could easily go to a clinic and they'll be able to test for all of them, outpatient clinic or an urgent care, or if you have, COVID test kits at home, you could run a COVID test. If it's not COVID, it probably is the flu. So in this season right now, if you get sick, it's highly likely that it's COVID, that is flu and not COVID. Although it could be any one of them. It could also be RSV, which also is hard to distinguish as well.
All right. Since I see no hands raised, I'll take a question that is in the chat. How prevalent is the receptor for bird flu in humans? Should we wear masks and other PPEs when interacting with birds?
Yeah, so my first response to that is it depends on where. So in the upper respiratory tract, our airway epithelial cells, all the way up here, are the receptors that the bird flu virus can't easily bind to. Those are the alpha-2,6. Those are what the regular H1N1 flu virus binds to. But lower down in the airway, in the lungs, you actually have lots of receptors that the bird flu virus can bind to, which means that numbers matter. If you're exposed to a higher number of the bird flu virus, it will most likely make it lower down in your airway, where it will actually bind to those receptors that it can lead to an infection for you. And that's why you see it's sporadic. We've only had 60 something cases over the last year of human infection with the bird flu because it takes that much. And in fact, for many of the infections that we've seen, like on the farms, these farm workers got infected in the eyes, right, and not in the respiratory tract. Although we've seen farm workers who have gotten respiratory infection, it splashes in the eye, causes an infection there that leads to conjunctivitis rather than a respiratory tract infection because the receptors that bind more readily to the virus is actually in the lower airway. So it's not so much the number, but where in the airway you are physiologically.
Okay, I'm gonna take Tessica because she said she'd like to add something. Then I'm going to take another question from the chat, then Lenny, then Wilpert. Dr. Tessica, you can.
Yeah, I guess I just wanted to add to the conversation because, you stated you are concerned. So what I'm a clinical microbiologist. I run the microbiology lab within the hospital. And so one of the things that we do in conjunction with the CDC is that whenever there's someone who is hospitalized with the flu, on the laboratory side, we can type, so we can say, yes, this is flu A, flu B. But one thing that we were noticing in the hospital is that when someone would have bird flu, it would be untypable. And so we have instrumentation within the lab that we can actually type to see what level of flu the person has. And so that's been one of the ways that we on the on the scientific side and the diagnostic side that we've been kind of staying ahead to see whether or not patients who are hospitalized are really present, with H5N1 or just typical seasonal flu.
Yeah, yeah, that's good insight. So what uh, she's talking about there is the fact that, because of what we're dealing with, you really want to be able to type it, and it's labs like the ones that she works at that you actually have the typing happen. And for us, whenever we find a sample, we typically send it off through the CDC to regional labs that have the capacity to sequence as well, so we can actually get a deeper understanding of what the virus is. And many times, Taskar, what we get back is just the HA typing.
Correct.
Many places don't do the NA.
Yeah. Yeah, I think what a lot of certain platforms, do only just say the H.
Right.
So having the right, platform to be able to type that far out has been, really helpful. Yeah, I agree.
Yeah, we do need at this point to know if there is any variation either in the HA or the NA. And so, just giving the HA typing alone has never been adequate for me. But I realize that, of course, I just really want to know the entire genetics of it. And if I can actually see the amino acid sequencing, I also prefer that rather than just giving me the genotype. But again, that is enough for us to know, are we dealing with the same thing or have we had shifts?
All right, let me take this question from the chat and then I'll go to Lenny. What are the implications of a full blowout in the holding areas given the mass roundup of immigrants by the Trump administration?
Well, whenever you have a lot of people in any, congregating in any one area for whatever reason, there is always the possibility and a higher probability of infectious disease outbreak. And, to be honest, I would be more concerned about cholera and maybe even measles or some other thing that people might not have been vaccinated for in those areas than even the bird flu. I mean, of course, if somebody in those locales have influenza, you could certainly have an outbreak. But I would be very much concerned about other types of infectious diseases. And, certainly those are things that they look out for. You have people there who monitor and who make sure that sick individuals are taken care of quickly, because that's that type of thing that could get out of control pretty quickly.
Good. Dr. Lenny?
Yeah, I have three questions, but I was just going to add some of the patients, some of the people you see may be farm workers, a lot of them that are being rounded up. So that presents a problem. We don't know what they've been exposed to.
That's right. I mean, if they were working on a farm, for example, a cow farm right now in California or Colorado or, Wisconsin or Michigan, that's something that you really would have to be thoughtful about, because they very easily have been exposed to bird flu. And then, again, in a congregate setting, as the previous question was, if they now pick up an H1N1 on top of that, then we start cooking and you're talking about a different situation. So those are my concerns.
Okay, thank you. My question now, the conjunctivitis.
Mhm.
Are the receptors on the cornea or the conjunctivitis similar to those that are in the airways?
Yes. So it turns out that there are certain types of conjunctival cells that have the alpha 2/6 there. So it's not even the alpha 2/3. It's actually 2/6, but the virus is able to bind loosely enough. And since the eye offers that protection, the eyelids offer that protection, it gives it an opportunity to attach and enter the cells. And so that now becomes the route for having that self-limiting conjunctivitis. It is self-limiting.
Does it cause the thinning of the blood? Why the hemorrhaging? Is it mostly from the coughing, you would think, or is it actually affecting the blood?
Yeah, I think, it's viral numbers, and over time, as the viral numbers increase, as you start having more inflammatory markers, you're having pro-inflammatory cytokines, you literally have almost a cytokine storm. And that now leads to damage of smaller blood vessels in areas where they are. And then that is where you can get some level of hemorrhaging. And of course, in the eyes, as you know, the blood vessels there are really small. Very fragile. Any increase in pressure could actually cause them to break. And so with that irritation that comes from having that conjunctivitis with viruses replicating at high numbers, that can lead to bleeding and that hemorrhaging.
Do you know if there's always corneal involvement or usually? Because I've had one patient that I can recall with two hemorrhages like that. I almost never see that. And this is the first time I've ever seen double hemorrhaging. But that never entered my mind as a diagnosis. And they seem to have recovered fine. But
Yeah.
that is a little scary.
I don't know if the cornea is always involved. I mean, for me, sometimes when I look at these reports, the physicians don't give a lot of information beyond the fact that, I'm reading case studies from the England Journal of Medicine. I'm getting information from the USDA and from the FDA. So I haven't gotten that level of information to see how often there's corneal involvement, but that's a really good question. Now you've set me on a course to go find that information.
Well,
Thank you.
well, doctor, just to let you know that Prince Talking does collect a royalty on those questions.
Can I add something
Dr.
there from a clinical point of view? The probability that a physician will
Sorry, Dr. Carrington, I'm going to disturb you. I had Wilpert first, if you don't mind.
I was going to add something to the comment.
Okay, all right. Okay, go ahead.
That's all. I'm not going to.
Okay, good.
I put
Okay,
my
good.
question in the chat already.
Okay, good.
From the clinical point of view, the level of suspicion of a patient having a conjunctivitis from bird flu is going to be very low under the circumstances, especially if that conjunctivitis starts to heal on its own or to heal with routine treatment, basically. So to take the swab, to send for culture, etc., will be less likely to be done under those circumstances. That's all I wanted to say on those circumstances.
Except that, because of the current situation that we find ourselves in, taking a good clinical history is so vital.
Correct. Always is.
You know, have they been on a farm? Have they been associated with anything farm-like? Do they have cows that they're milking? Are they drinking raw milk? Which, believe it or not, people are still doing, even with the current threat from bird flu. So I think taking a good history will give you an idea of whether or not this is something that you really want to take a swab of and send off. If this person has been in contact with outdoor flocks of birds, if they have been in contact with an animal that was sick, any one of those things would be indicators.
Agree.
Good. Wilpert? Wilpert, you're on mute. Unmute yourself, Wilpert.
Yeah. Okay.
Good.
Yeah, Dr. Webley, thank you so much. You know, you as a specialist have a leg up on the regular PCP and the regular emergency room doctor. So if I feel ill and I feel that I might have come down with something like a flu, where's the best place for me to go?
Yeah, I would, if depending on how sick you feel, I would go to my primary care, because in these times, your primary care physician would suspect influenza and would certainly go ahead and do a test for influenza, and those tests are simple enough. But you know, short of that, going to any urgent care area, they would certainly, as Dr. Reed said, you know, they have very specialized equipment in some of these clinical labs where they can actually type the virus. And so if you come up positive on a quick test, they're definitely going to send that sample out just to see what it is that they're having. Unless, of course, you know, maybe you know, you're in a rural area and they're not able to get to those services overall. But I would trust my primary care. These primary care physicians in this season are really looking out for this, because they're seeing it often enough that they know that it is something that's on the horizon. And we're at the peak of flu season now. You know, flu season started in October. It's extending out now to February. By end of February, we expect that flu season will start going down and going away. That would give us a sense of relief. But right now, I would say go to your PCP.
So, doctor, oh, sorry, Wilpert, go ahead. Sorry, Wilpert, I'm sorry.
Because, you know, I've been the beneficiary of specialized biomedical engineering interventions, put it that way. I've gone and I went to my PCP and he said, "What is that?" And I had to give him a lesson on it. And I went to the urgent care and the doctor said, "What is that?" I had to say, "Call your nurses and I'll call you all your available medical personnel. Let me give you a course right here." You know, and I realized that these people had no idea about the intervention that I had.
Yeah, and as you qualified it at the top, Wilper, because you say specialized biomedical intervention, which means this is not typical care. And if it's not typical care coming down from the AMA, those doctors would not know, because remember where they spend most of their day, right? Most of their day is spent seeing patients. Maybe once or twice a year, they get a chance to go to a conference where they get, you know, continuing medical education, and they get to hear some of these new cutting edge things. And when they have a little spare time in between meals, maybe they read something in the popular press or something coming down from the CDC or something like that. That's how they get their information, because, you know, you come out of medical school, you know what you knew then, you specialize, you know what your specialty is offering. When you're a primary care physician, you're spending a vast amount of your time taking care of patients, and you learn from your patients. Based on the diagnoses that are coming up, you see something you don't know, you send them to a specialist, you have a suspicion, you refer, and through that referral and what comes back to you, you learn from it. But there's nothing special about them that would make them know cutting edge information that is not in their wheelhouse. So good for you for helping with the education of your medical personnel, because now they can go and look and say, oh, my patient told me this, let me go look it up. The same thing happens to me when I teach, Wilbert. You know, I go into my class, I think I'm the expert in this area. A student come and say, I saw this on TikTok, and I'm like, I've never heard about that before. I don't dismiss it. I go home and I take a look at it and I realize, oh, there was some paper that came out, didn't get a lot of press. This thing is there, it's circulating. I go and I do some referencing to make sure that the evidence for it is robust. And I go back to my class and I thank my students for sharing it with me. And I tell them what I gleaned from the information that I now have. That's how knowledge is. You know, when you think about the knowledge, if you think about knowledge as a big circle, the amount of information that you have coming out of high school is a dot in the middle of it. You know, you get to the place where you get to college, if you're so lucky, and that dot gets a little bit wider, right? And then if you get to do a graduate degree, now it's not broadening that circle, but it's coming from that circle and narrowing, going to the very edge of knowledge, right? At the and getting a PhD or something like that, you have to add new knowledge. So it's just a poke in one corner of that circle. The rest of that circle is all this stuff that you don't know.
Mm-hmm.
You know, and so over time, if you're voracious in reading and in picking up information and listening to people around you and always assuming that somebody has something to teach you, over time you'll increase in the breadth and the width of that knowledge, but you'll never get to the place where you know all of it. So, you know, that's what happens in medicine. That's why they keep calling it a practice. You keep practicing, and you know, maybe at some point you'll feel that I've gotten it good enough that I can take care of who comes to me. But you never really get to the place where you have it all together.
So, doctor, the question was asked earlier about wearing masks with when interacting with birds. Are potential is potentially mask going to become a part of our everyday existence? With in other words, will you be wearing mask as a part of our regular routine, like we're like wearing a pair of glasses, or are we finding out that these seasonal outbreaks are becoming longer, and therefore they are more challenging to manage? Or would you say that the authorities have a good management control over what is happening?
Yeah. So masking should be worn as necessary. I'll put it that way. In other words, if you're going into an unfamiliar setting with people who are sniffling and sneezing, I would say wear a mask. You know, the last time I was on a flight, I wore a mask because I felt like it was necessary. You know, flu season was just getting going. There were a lot of people sniffling and sneezing, so I put on a mask. In terms of bird flu, unless you're working directly with birds, or you're working with birds that you know that look sick, and then I would say you need more than a mask. You need PPE, you know, and you need to wash your hands and you need to cover your eyes. So it would be more than a mask then. In terms of the seasonality, I would say yes, there have been changes in what we're seeing in terms of seasonality of certain diseases. Not necessarily where bird flu is concerned, because this bird flu outbreak has not really waned over the past year. It's just been ramping up and ramping up and ramping up because of the number of new hosts that we see being affected. So it doesn't really care much for the season, except that as you have migratory birds, as you have these waterfowls that migrated south, as they're coming back now after winter, they could potentially be coming back. And as they make their stops along the way, going back up north, they could very well have a lot of bird flu with them that they're going to be spreading, and that could be problematic. But I think, you know, what we're seeing over time is that we're seeing that our seasons are not operating the way we know them to be. You know, we're having winters that don't feel like winters, and you're having vector borne diseases hopping around and popping up in areas that we hadn't seen them before, because whatever the transmitting or the reservoir vector is able to live longer, you know, whether that's a mosquito or certain types of flies or other types of parasites that used to be affected by winter. Now we're seeing that, you know, the change, the climate change that we've been experiencing affects that. That probably is not necessarily the case with influenza. but it's certainly the case with other types of transmissible diseases that we see going around.
Doctor, there's a question in the chat from Charmy. Would you care to address that?
Remember that meds interact, Tamiflu especially may interact with blood thinners. Yeah, and that's why you would definitely need your doctor to prescribe that. They would know what you're on and what they can give you. But Tamiflu is not the only choice you have. There is a whole host of antivirals there that you could choose from. And you know, people are trying to develop monoclonal antibodies. One of the things I didn't tell you is that there's actually there are actually 3 vaccines out there against bird flu.
Doctor, be careful now. Be careful. You're talking about vaccines.
Yeah, I know. I'm a vaccine advocate because vaccines work. And the people who tell you that they don't have a lot of things to learn. So there are bird flu vaccines out there. We haven't been giving these vaccines overall, but those vaccines are present and available. And so, you know, essentially what you have out there is that you have these vaccines that are specific for H5N1, the Seqirus vaccine, inactivated vaccine, GlaxoSmithKline has a vaccine out there, and Pasteur has a vaccine out there. All of them specifically made against H5N1 human flu vaccines. And the EU has been giving these vaccines to farm workers, right? So essentially, they have been mitigating this already, giving it to farm workers, as opposed to the US that we just haven't done this. We just haven't been giving these to anybody overall, but you know, we have things that can help.
Okay, Wilbur, do you still have your hand up, or should I move to Dr. McCullough?
Yeah, I was trying to lower it, but I can't get.
Okay, all right. Then we go to Dr. McCullough. Go ahead, Melanie.
Well, actually, the question is mine.
Go ahead, Judith. Go ahead.
Dr. Webley, thank you for everything you get to say. And it triggered for me a question that I've wanted to know for a while. In 2005, I got a bad case of the flu. Yes, I did have my flu vaccine. So I'm letting you know that part. In 2006, January, I recovered in December. I got it in December and I recovered in December. I was feeling fine by the middle of the month. In the beginning of 2006, like the first week, I started having strange symptoms. I started smelling rotting fish. Now, to make a long story short, yes, I had an encounter with fish. There was a dead fish on the road. I did have to run over it. I had my husband wash the car. He said, there's nothing in the car. There's no sign of it. It continued for weeks. Eventually, I woke up one morning and I had no sense of smell or taste. I went to the doctor and the doctor asked me multiple questions, had me go in and have tests done to see if I had a brain tumor, et cetera, et cetera. And it basically said, you have gotten a virus and the virus has destroyed your olfactory nerve. And that's why you can't taste or smell. Fast forward then, several months later, I recovered the sense of, I could smell lemon. Then like 3 months after that, I was able to recover some natural smells. So that's been a very long time. My sense of smell started to return, but it came back changed. And he said to me, it was like this originally. When it was destroyed, it came back, but things didn't match up properly. And so certain things I cannot smell. I cannot smell burning. I cannot, and the smell of perfume smell like garbage, and other strange kinds of things happened. So my question to you, when I heard that COVID was producing a loss of taste and smell, I wondered, do you know of other viruses that also have that as a side effect? Because I know it's a serious thing.
Yeah.
That was 2006.
Yeah, what an interesting case that is. You know, COVID definitely is a type of virus that can do that. But as you started talking about the fish smell, I remember that, trimethylaminourea. You know what that is? TWAU?
No.
It's really a metabolic disorder. It can be genetic, but it actually makes you, it's a metabolic disorder that makes that person smell rotted fish smell. Which is interesting. And, I don't know if a virus can cause this, but, there could be something there with the damage of the olfactory nerve bundle. I don't know many viruses that can cause this. In fact, I don't know that apart from COVID, I know any virus that can lead to that smell. I don't know if Dr. Reed knows any other viruses, but COVID really is the one that I've known to cause parasmia. I think, if I'm not mistaken, I think influenza and parainfluenza could cause that as well. Yes, parainfluenza virus and possibly influenza could cause it, but not to the rate that we saw with COVID. Certain enteroviruses as well, now that I'm thinking about it, based on the way they infect, could also lead to that because they're actually able to get into the nerve bundle. So all the viruses that are able to get into the nerve bundles there in the olfactory system could potentially lead to short-term loss of smell. But COVID was just really good at doing it because of the numbers that it replicates to.
Yeah,
Sorry, Doctor.
the doctor told me, just one second, the doctor said to me that the smell probably came from the destruction of the nerve. At the time I was smelling this for several weeks, it was probably being destroyed. That's what he said. I have no idea if any of this is accurate because, we just have to depend on what people tell you because you don't have that knowledge for yourself. But the good thing for me is that most of smells have returned.
Good.
But my husband would tell you, I still can't smell burning.
I just posted that flu and COVID are known to cause it, but so does Epstein-Barr.
Okay.
So EBV apparently can lead to loss of smell as well. Thanks, babe.
So, I was going to invite Charmaine to make that point that she's making in the chat. Is that your wife, Doctor?
My wife. Good luck getting her to talking.
Okay, good, no problem. Any other question?
I'm going back now to the conjunctivitis and the hemorrhaging. Does it produce hemorrhaging in the lungs too and part of the respiratory tract?
Not that I've seen. That would be unusual, but again, both organs have very small capillaries. And I think it all depends, for COVID, for example, we saw significant damage of lung blood vessels because of that. There's no reason to believe that a really bad case of influenza wouldn't be able to do the same thing. Of course, again, with a virus like COVID, it replicates to such a high level in the airway that it's the numbers that actually drives a lot of this pathology. But I haven't seen any publications that I can remember that talk about compromising of blood vessels and hemorrhaging in the lower airway from an influenza infection.
Okay, doctor, you mentioned earlier about some of the preventative methods that we can utilize, that we can use to ensure that we protect ourselves. There are some people who are just joining us. I'm going to ask you if you can go over some of those preventative strategies that we can put in place to ensure that we are protected from these viruses.
Yeah. So let me pop back up a screen here. Hopefully you're seeing that.
Yes.
And so, essentially, let me go back here. Extra slides. All right, here we go. So, you know, the first big thing, prevention, avoid contact with any animals, birds that look sick, wild birds. If you're walking along a pond, if you're walking a dog, for example, keep your dog on a leash. Don't let them pick up dead birds or sick birds. You know, same thing if you have indoor cats, keep them indoors. Don't let them out because if they eat a dead bird or pick up a dead bird that has bird flu, then of course that's going to make you susceptible. In terms of eggs, it's unlikely that you would get bird flu from eggs, but to be safe, you know, make sure the internal temperature of your egg is 165. In other words, if your egg is runny, it probably is not well cooked. And in these times, you probably want to do that. Washing your hands. Hand washing is really just the very best thing to do. In fact, one of the infections that we're contending with, not a respiratory one, is norovirus. And norovirus infection is very serious. A lot of people have come down with very serious norovirus infection. And hand sanitizers don't kill norovirus because it doesn't have an envelope. And so really washing your hand with soap, something that's really sudsy that makes you wash for a while with warm water or even cold water is a very good thing to avoid contaminating food or contaminating yourself. We touch our faces, our eyes, our nose, our lips many, many times throughout the day. So washing really well is important. And then of course, not waiting too long to seek medical care. If you're home and you think you have something, you're not really sure, but then you look and you realize that you know it's not going away. It's really important to go in and get checked to make sure that you know you don't have something that's unusual. New infections are popping up all the time. These viruses are mutating all the time. You want to get checked to make sure that you don't have something unusual that's going to prolong your illness. And of course, what I didn't have on here in terms of a strategy is to keep healthy. You know, eat well, exercise when you can, you know, leave out a lot of the comfort food as much as possible. Although that's hard, especially with a new administration that leaves a lot of us needing comfort. You know, you know, people might binge on comfort food, but you kind of want to make sure that you're taking care of you. If you have underlying conditions, even more so, you know, if you're a person who is obese or overweight, if you have diabetes, if you have heart disease, if you have an autoimmune disease, you want to be up on your vaccines. If you got the flu vaccine this season, it offers some protection against the bird flu, not a lot, but some protection. And certainly offer a significant protection against the seasonal flu. You get your COVID vaccine. There's an RSV vaccine out there that you can get as well. And especially for people over 60, getting an RSV vaccine is really important. If you're a pregnant woman, getting an RSV vaccine not only protects you, but protects your baby. There's a specific RSV vaccine for that. So again, there are a lot of things out there that you can get that offers a significant level of protection. And maybe as a preventative, try not to get down the rabbit hole of conspiracy theorists online. That also is really important.
All right, iPhone 221. I'm going to invite you to participate by asking a question in person.
6 o'clock.
Versus reading what you're saying, because we get a better appreciation of your question if you were to ask it. Would you mind doing so, please? I guess not. Okay, doctor, the question is in the chat. Long-term COVID is the worst and is still unknown. What does the future of pandemics and epidemics with the constraint in funding to support the CDC, HHS, and NIH, WHO, World Funding, etc. Will it go to all the states? Do you expect millions to lose their lives globally and here in America? We are in unexplored times public health wise. What are your thoughts on that?
Yeah, it certainly sounds like somebody who is in the medical field and or in the research field. This week, as somebody who works on a university campus, that's an R1 campus. In other words, we're a Research One campus. We get just under $300 million in research funding each year from the federal government and other, sources to fund research on our campus. And when this new administration came in and sent out an executive order to halt all expenditures, it sent an upheaval. Because a lot of this research that's ongoing is on some of these infectious diseases. NIH funds projects on infectious diseases. NSF funds other type of projects, but almost every project that is funded through the NIH has to do with some disease and disease mitigation. With the US deciding to pull out of WHO with very flimsy reason as to why. The immediate impact of the funding to the WHO is not going to be felt this year because the funding that the WHO has gotten is already in place. So that funding impact will not be felt for another several months. The impact that is immediate is the fact that the WHO works hand in hand with disease detectives and other experts from the CDC. And these CDC employees have been prevented from having any interactions with the WHO. So what the WHO is having right now is a brain drain. The CDC collaborate with WHO in having these investigations. Right now, we're having an Ebola outbreak in the Congo. We're having a Marburg outbreak on the African continent. We're having Mpox outbreak, and I could go down the list. We're having a tuberculosis outbreak right here in the United States, in Kansas, right? And so when you have these outbreaks and the WHO doesn't have the expertise from the CDC experts, a lot of these things that could have been mitigated might just go by. We don't know yet. And so the last part of this question is actually the big part. We are in unexplored times in public health. And, I'm hoping that it doesn't reach that place where people lose their lives because of this type of decision making. I'm hoping, I'm the first to tell you that the WHO, the World Health Organization, needs some reform. But the World Health Organization has no power as an organization. It can't dictate to countries what to do. It has no power to. What it is good at is corralling expertise from all member countries to mitigate infections so that we don't have massive outbreaks wherever they might be coming from. And every single day while we sit in our homes and we sit in other places, there are infectious disease outbreaks that are looming that we know absolutely nothing about, that we would never know anything about, that somebody is taking care of. Let me show you something right now that might surprise you. Let me share my screen again and show you something here. And my students, when they come into my class, they're always pretty surprised at the number of things that they were just unaware of. Where are we here? Let me just do my screen. Sorry. ProMed Mail. So are you seeing this page on ProMed Mail?
Yes.
All right.
Yeah.
So this is a website that does web crawling, and it lists and tracks all infectious disease outbreaks across the world in real time as they're popping up, sometimes even before we know what exactly they are. It's not for the faint of heart, but this is where infectious disease specialists go. And you can see over here just today, there's an Oropouche virus outbreak in Brazil. There's a Q fever outbreak in Australia. There's a meningitis outbreak in Ghana. There's a Lassa fever outbreak in Nigeria. There's a measles outbreak in Canada. There's a botulism outbreak. There is measles in the US, right? There's a rabies infection somewhere. Of course, we have avian influenza, not just here in the US, but in India. There's a salmonella outbreak in Canada. All of this over the past week, there's a tuberculosis outbreak in Kansas, right? There's a case of polio in Pakistan. There's Zika virus outbreak in India. There's Ebola in Uganda. There's another avian influenza outbreak in Cambodia. Same H5N1 that we're dealing with. Their poultry is getting hammered with it. There's Mpox outbreak, monkeypox outbreak in the UK. There's a cholera and dysentery outbreak in Sudan, right? And anywhere you have any wars, you have these outbreaks. There's a African swine fever outbreak in China. There's foot and mouth disease still causing havoc in Indonesia and other parts of Asia. So again, a lot of people just sit by and they really don't know what's going on. And you know, you scroll through the past week and you see these outbreaks, and in the midst of that, to think that you do not have all the expertise around that you need, and it start becoming scary for those of us who live in this space and know that this is ongoing.
But doctor, I mean, okay, doctor, I hear you and I see you doing all this, sharing all this with us. But we now have a president that says he's the smartest person. Why doesn't he know all of this?
Because when you surround yourself with people who are anti-science for the most part, when you surround yourself with people whose ideologies do not reach the ground to regular people, this is what happens. You know, a president is not expected to know everything, right? So you surround yourself with advisors who can give you good advice. And, you know, I think unfortunately he's surrounded himself with people and is planning to surround himself with even more people who have spent their lives and their careers pushing anti-science tropes and making scientists out to be enemies of the people who have dedicated their lives to doing this. And I think it's very short-sighted, because infectious diseases don't care who you voted for. Infectious diseases don't care which part of the state you live. We live in a global environment where somebody can be in one continent this morning, and the next by afternoon they're in a completely different continent, and they could have picked up an infectious disease there, and by the time they start getting symptoms, they've passed through several airports, several ports of entry, and landed somewhere in midst of vulnerable people, and that's how an outbreak starts, right? And so this America First isolationist type of thought process that we're seeing doesn't serve anybody well, because we don't live in the era anymore where we ride horses and buggies everywhere. We don't live in the era anymore where we get on steamships and it takes months to reach the next continent. We live in a space and time where transport and travel is such that we get from one place to the next in a very short time. We live in an era of urbanization where lots of people live very close together in big cities, where all you have to do is to have one infectious disease victim, and it spreads very rapidly to all over the place. So I think with that in mind, we just have to watch and see. You know, people like me have no more power to make change than to talk with people like you who vote and who can influence your local state representatives and national state representatives to say, hey, you need to get a handle on this or somebody's going to die.
Errol?
And then to make matters worse, we are about to, well, not we, they are about to put in place a gentleman to run the Department of Health and Human Services who has no qualifications to lead this important portfolio, which, if that happens, Wilbert, as we say in Jamaica, you're a goose cook.
Mm-hmm.
But you know, it gets even more interesting, Wilbert. You talk about the fact that WHO is being defunded. Marcel and I have a very good friend who works at the UN. And he is complaining to me yesterday that because of the executive orders, all of the funding for his entity outside of the United States has now been withdrawn. So he is in a very faraway country. And according to the US, they don't care about this faraway country. But in that faraway country, there are thousands of Americans who work for the UN there. They are trying to ensure that the very best healthcare is provided in those countries. But it's not just for those persons. It's for the global environment, because as you see, people move around the world. So in defunding or withdrawing from the World Health Organization, Trump is actually endangering the lives of Americans without even realizing it.
I do not disagree with you in the least. I mean, we look and we see programs like PrEPFAR, that was started under George Bush, being terminated. PrEPFAR is what funds medications to individuals with HIV. HIV is going to be the forgotten pandemic that has already killed over between 35 and 40 million people. And there are millions of people around the world who are infected. What people don't realize is all you have to do is to stop HIV medication for just a few days. And that virus that was in remission, that was undetectable, comes racing back because you have viral stores around the body, especially in the lymph nodes and other areas. And they just come back raging and could mutate, which means that the medications that you were using to treat them, by the time you start medications again, it might have no or little effect on them. So this is kind of the era that we're living in. And, you know, the truth is, I don't understand a lot of it. I don't understand how you can put somebody in charge of Health and Human Services who has spent his life telling people not to take vaccines, telling people that all of these medicines are terrible, while you're monetizing and making money off selling onesies that say do not vax. You're selling products that have been proven to have absolutely no effect. And you're pushing them and monetizing something that you know are not going to help people. A lot of us get into these areas of our professions because we care about people. We want to effect meaningful change in society. And it is antithetical, it is foreign to me that somebody can come and push for positions like these, knowing that you're not going to effect the type of change that is necessary, knowing that you're not going in it with the right intentions, riling against diversity, equity, and inclusion when you don't even know what it means, while at the same time throwing up all of these decoys all over the place to distract people while their lives are being put at risk. But, you know, again, in a democracy, democracy is messy and people get what they vote for. And, you know, this is what the American people voted for. Whether or not you say that's what you thought, that's what we voted for. And that's what people have to deal with for now until people start pushing back and asking for change. You know, that's how democracies work, or that's how they're supposed to work. Again, we're in uncharted times.
Okay, doctor, someone texted me a question. The question is, and then I'll take Dr. Carrington, he'll be our last question for the evening. How susceptible is one to get the flu more than once in a flu season? Do they form antibodies to help prevent the infection reoccurring?
Yeah, it would be highly unusual to get the flu in the same flu season because what is circulating is pretty similar. But I could see one who wasn't vaccinated, because remember I told you that the vaccine is not just against one flu strain. This year's vaccine is against 3 different ones. So I could see you getting one, right? And then being unlucky enough to get another one. But you wouldn't get the same strain because you would have enough antibodies against the strain you got to protect you in that season from getting that one again, but it wouldn't necessarily protect you from getting another divergent strain of the virus.
Okay, thank you. Dr. Carrington, you're the last question for the evening. Go ahead.
I would just add to what he just said, unless the person is immunocompromised or they did Well, you could answer the rest, Wilmore.
Yeah.
But my question is, do you think the reason for the high flu counts in the past 2 years has been the fact that we are no longer as protected or as protective, I should say, as we were when we were in the COVID era where we were wearing masks. Nowadays, a lot of people don't wear masks as much to prevent from the flu, and we see the or other protective measures for that reason, hand washing, etc. And all those things could become complicating the fact that the flu prevalence is rising, basically.
Yeah, I think there are two things. I think what you've said is one of them. That, certainly you saw what happened when I showed that graph. You saw 2019, you saw 2020, right. Then 21, almost nothing, right? If you're not out and about, if you're not interacting with people, you're not going to get flu. It's a respiratory infection. It's a contagious respiratory infection. You're not getting it if you're not out and about. But the second thing that has happened is that after COVID, what has happened is that anti-vaccine sentiments are running so very high. So the total number of people who are getting vaccinated has actually gone down significantly.
Wow.
So vaccine uptake for influenza, as it is for almost everything else, is almost at an all-time low. It's affecting everything from MMR. You saw in the ProMed stream that I had there, 3 different accounts of measles outbreaks, not just here in the US, but in Canada and parts of Europe. And a part of that is that, measles is such a contagious virus.
Yes.
If you had measles and you rode an elevator and I rode that elevator 2 hours after, I would still get infected.
Mm-hmm.
Right? Because that's measles for you. Highly contagious, hangs around in aerosols for a long time. And so as a result of that, you need a high level of herd immunity, over 90%, in fact, over 93%. And what we've seen is that number continues to drop in many areas. And so that level of protection is not there. We're seeing that as well with polio. Polio that we thought was eradicated is coming back. You're finding it in the wastewater. You're finding it in other countries because people are just not getting vaccinated. And because of the high anti-vax sentiment in the Western world, we're seeing places like Afghanistan, for example, that have very serious terrain, a place that they've really tried to stamp out polio. One of the last set of polio vaccinators that went up in the hills, they were all killed, right? And the people who were doing these killings, a lot of them have talked about what they've seen coming from the United States in terms of anti-vax sentiment. So these things reach far and wide and they have an impact. And I'm afraid that it's not going to slow down anytime soon.
Sad, sad, sad.
Dr. Webley, thank you very much for sharing your insights this evening. We are all better off 2 hours later for having learned all that you have shared with us. And we look forward to you updating us whenever there are any new strain, any new updates that are available. We are happy to be your scapegoat for your research and sharing peer group reviews with us.
I'll keep that in mind.
Yes. We're also delighted to see. Sorry, doctor. Go ahead. I'm sorry.
Always good being with you guys. It's a pleasure.
Thank you. We're also delighted to see Dr. Holness with us. He says in the chat that he's feeling a little better and he's with us and he enjoyed the afternoon session. Thank you, Doctor. To God be the glory. We're happy that you're recovering well, and we wish you all the best in your continued recovery. Dr. Carrington, may I ask you to pray for us to close, please?
Okay, will do. Let's bow our heads. Almighty God, we thank you so much for the insights that you have given us in this particular conversation this afternoon. I thank you, Lord, for Dr. Webley. You use him mightily with the word and you use him mightily with the science. I pray that you'll continue to bless him, bless his family, use him for your glory. And for all of us who listen, Lord, I pray that we will be the most aggressive advocates possible to tell people about the challenges that we face in our country and to help them to better understand them and hopefully to raise up a campaign against ignorance, against um, uh, foolish thinking, and help us to help the world and help our communities to be better. I ask these blessings in the name of your Son and our Savior, Jesus Christ. Amen.
Amen. Good. Thank you very much, gentlemen. Thank you very much, folks, for our first session this year. And we look forward to having you. I will be informing you as to who will be our next guest. Doctor, thanks again. And have a wonderful evening.
All right.
Bye.
Bye-bye.